Welcome to the Respiratory Research Report. I am your host, Dr. Albert Rizzo, Chief Medical Officer of the American Lung Association. Today's report is from Dr. Peter Miller, an American Lung Association recipient of an Innovation Award, supporting his research at the Massachusetts General Hospital in Boston. His research topics include basic biologic mechanisms, immunology, immunotherapy, risk factors, and tobacco. Today's discussion is around his interest in COPD. Dr. Miller, please tell us about your current work, which I understand involves the study of DNA mutations in blood cells and the term clonal hematopoiesis and its relationship to COPD. I believe you mentioned recently you had published in this area.
Yeah, thanks so much for having me, Dr. Rizzo. It's really a pleasure to be here and to be able to describe my work to you for a few minutes. So as you mentioned, my background is in hematology. I'm a hematologist oncologist, and I happen to find myself in the exciting world of COPD through clonal hematopoiesis. So this is what my lab studies, and it's a phenomenon in which individuals acquire mutations in their blood cells that accumulate over time. Now, we know that people acquire mutation in their blood cells every day as every cell divides, and usually that creates no problems. In the most extreme cases, those mutations in the blood cells can really cause those cells to grow abnormally and lead to things that many of us have heard of: blood cancers, leukemia, things like this. But there's a state before those leukemias ever could develop, and that's what we call clonal hematopoiesis. So these are individuals who are otherwise hematologically in their blood totally normal, but they have these mutations in their stem cells. And what we've now come to learn over the past 10 years or so is that when these mutations are present in their blood cells and not really causing any problems in terms of blood abnormalities, they still can cause aberrant inflammation in different blood cells that carry those mutations. And the first observation that was made about 10 years ago now is that individuals who have clonal hematopoiesis, which once you reach the age of 60 is about 10% of the population, they have an increased rate of developing cardiovascular disease, heart attacks, and strokes. And that's thought to be because of accelerated inflammation in the vasculature, in the blood vessels, that can lead to higher rates of blood clots and impaired blood flow. So based off of those observations, we hypothesized that there could be other kinds of diseases that develop because of aberrant inflammation, in which clonal hematopoiesis could contribute, as it does in cardiovascular disease. And our first thought was, well, let's find a disease that is unfortunately relatively common, in large part due to cigarette smoking, and something that has a pathophysiology, an underlying driver that is related to enhanced inflammation. And we thought that COPD would be a good disease to study this. So in order to address the question first, we looked at a cohort of individuals, about 50,000 patients, who have been tested in their blood to see whether they have clonal hematopoiesis. And we have all of the clinical information on these patients. And we asked the relatively simple question of, if you have clonal hematopoiesis, are you more likely to either have or to develop chronic obstructive pulmonary disease, as we saw in cardiovascular disease? And to our surprise, the answer was yes. So individuals who have clonal hematopoiesis are more likely than other people who don't have it, of the same age, who have other similar comorbidities. And this suggested a very strong human genetic association that clonal hematopoiesis can be part of the pathophysiology of COPD. Now, as you mentioned, we're also interested in cigarette smoke, and we know that cigarette smoke is a major driver of COPD. What we learned from this study was not only does clonal hematopoiesis increase the risk of COPD independent of how much you smoke, so we control for the number of pack years, but we also learned that there's another sort of angle to this story, that cigarette smoke itself can increase the risk of clonal hematopoiesis. So we can have cigarette smoke linked to clonal hematopoiesis, linked to COPD, back to cigarette smoke. And so we're trying to figure these things out. And in the final part of that project that, as you mentioned, was recently published, we actually use mouse models. So I run a laboratory where we do basic mechanistic studies in addition to our human genetics. And what we did is we created a mouse model of clonal hematopoiesis. So the mice have these mutations in their blood cells. And then we expose them to different stimuli that can induce lung injury, either cigarette smoke or cigarette smoke with different toll-like receptor agonists. And what we were able to find, which is consistent with our human data, is that the mice that had these mutant blood cells had higher rates of emphysema in their lung tissue after exposure to things like cigarette smoke, which suggested that this is in fact a mechanistic link. Something about the abnormal blood cells is driving enhanced inflammation in the lung. And we're starting to get some information about what cytokines may be driving this process, but that's where that story ends and where the ALA award begins.
So I'm gathering from this, what might be implications of identifying this in populations? Are there going to be just increased risks, or do you figure there's going to be a target that might be able to change the course of the inflammatory process?
I think that is the key question that we always have to ask before we embark on any study. And I sort of think about it in two ways. I think about the biological and the therapeutic implications. And to start with the biological implications, I think that I'm interested in using our findings to gain a deeper understanding of what are the immune processes that are occurring in the lung that can drive COPD. So for example, if clonal hematopoiesis increases the rate of inflammatory alveolar macrophages, and that leads to more COPD, that can teach us more broadly about the role of alveolar macrophages in COPD.
Right.
Or, for example, if we find that the mutant cells have a higher expression of interferon gamma, that may teach us about the role of interferon gamma. And so I'm really interested in the biological implications of COPD pathogenesis through the lens of clonal hematopoiesis. And then therapeutically, as you said, I think there's two broad categories. The first would be prognostic, which is if you see somebody in clinic and they have clonal hematopoiesis, if they have risk factors, could you think about ways to sort of prognosticate their risk of developing COPD? And then very much therapeutic angle. So similar to what I just said before, if it turns out, and of course we don't know if this is true, that it's interferon from the alveolar macrophages, then maybe strategies to try to target particular cell types or particular inflammatory pathways could prove therapeutically beneficial for individuals with COPD.
Great. One last question. Does the rate of tobacco smoke or cessation, does that affect the clonal hematopoiesis over time?
Really?
Worth getting them to
Good
stop?
Such a great question. So we know the answer to the first part. We don't know the answer to the second part. So there's different types of clonal hematopoiesis defined as which genes are actually mutated. If you look at all clonal hematopoiesis, regardless of gene type, we do know that the intensity of smoke exposure is directly correlated to the rate of which individuals have clonal hematopoiesis. So, for example, if you smoke for every 10 pack years of smoking, you have a 5 or 6% increased risk of having clonal hematopoiesis. So we do think that there is a dose response, so to speak. And there are some particular genes where that dose response is even higher than all comers. What we don't yet know is whether individuals who stop smoking, does the clonal hematopoiesis itself decrease, or does the risk associated between clonal hematopoiesis and COPD decrease? I would like to think the answer is yes, but we don't actually have the longitudinal data sets of those cohorts to know the answer to that question.
Very interesting area. Do you have a particular clinical trial or project coming up that you wanted to talk about, or?
Yeah, so we don't have a clinical trial yet, but we're hoping that the projects that we're working on in the lab can make a foundation for sort of a prospective clinical trial. But really what we're trying to do now are two things. On the one hand, we're expanding our human genetic studies. We started with 50,000 individuals. We're now doing 200,000, and we're expanding that even further. And what we're trying to do is really refine the association in the human genetics of how these risk factors play together and potentially take advantage of different variations in DNA amongst that are different between different people to understand what other factors may be playing a role in these risks. Are there specific levels of different inflammatory markers in individuals that may be part of this process? And on the other hand, in our mouse models, we're really trying to dissect mechanistically what are the specific pathways, what are the specific cell types that I was alluding to before to understand where we should think about going after in the context of a clinical trial.
Very good. Well, again, I want to thank you not only for your time today, but for the work you're doing outside of your hematology to help the respiratory patient going forward with your research. We look forward to hearing more about this in the future. Thank you again.
And thank you very much for the time. I'm very excited to be in the COPD world, and I look forward to being able to make some progress for our patients.